Hi, this is Mrs. Lewicki, and this is part 2 of 3 voiceover PowerPoints on quality improvement. And this video covers the quality improvement process. There are going to be 15 slides. There are different ways about approaching the quality improvement process, but at the end it needs to be a systematic process. So it's a continuous, multi-step, multi-level process. It identifies areas for improvement based on performance and industry standards. And so they look at areas where there might be a lot of errors that have occurred, medication errors or injuries to patients or things like that. And they focus on an area to improve based on performance. Or measure the performance based on industry standards. Quality improvement process involves analyzing the current protocols of care and the outcomes, comparing them to outcomes of the high quality care, or benchmarking that's called, identify areas for improvement, researching factors that contribute to better outcomes, and implement changes to improve outcomes. And that's sometimes where there's some resistance, because as nurses we're often resistant to change. And analyze patient outcomes to determine effectiveness of changes after the change is made, and identify areas for further improvement. The facility providing better quality care should document the methods and then share them. And that's when we were talking in the earlier voiceover PowerPoint. That's why there are national organizations, because they will share what's worked for their facilities. Performance improvement is quality improvement is quality improvement is directly linked to performance of an individual, team, unit, or organization. There's an interprofessional assessment. It occurs within a group of individuals with similar positions in a healthcare system. So it's not going to compare nurses to respiratory therapists or respiratory therapists to physical therapists. It's comparing nurses to nurses, ICU nurses to ICU nurses, emergency room nurses to emergency room nurses. There's a peer review, professional critique of colleagues' work based on predetermined standards. And as I said in the earlier voiceover, those are the Florida Board of Nursing Standards, the National League of Nursing Standards, those types of standards. Nurses assess other nurses in safe, non-punitive environment. And that's where we struggle, because we want to avoid the blame game and you did something wrong. We really, they look at it as a Swiss cheese model, and when something can fall through the holes of a Swiss cheese, then it's considered a system problem, and it shouldn't necessarily be personal blame. Nurses analyze complicated cases, determine standards by which they will collectively be held accountable, and produces recommendation nursing staff will understand and accept. Ooh, that's the hardest part, is the accept part. There are regular audits that are done. So, and you will, when you are working, be required to do so many chart audits a year for your evaluation. And you're auditing somebody else's documentation is what happens there. But other audits include to make examination of records to verify that they're recorded accurately and used properly. Usually examines financial or medical records, can be for a single patient, group or of similar patients, individual clinician, unit, or whole facility. And it really depends on where they're targeting the quality improvement. Interprofessional is focused on one discipline. Interprofessional is more than one discipline. And a retrospective audit is they are looking back to evaluating performance after patient's discharge, and recommendations made to change procedures if needed. Concurrent audit is performed while the patient is currently undergoing care, and we may need to make changes to prevent adverse events or improve patient care. Again, interprofessional assessment, they're looking at outcomes management. So uses the patient experience to guide improvement by providing link between medical interventions and health outcomes, and between health outcomes and the cost of care. Outcomes management system implements evidence-based practice systems, and that's why we do spend a lot of time talking about evidence-based practice, and you are going to hear that throughout the nursing program and in your practice when you're a registered nurse. Guide case decision making, incorporates better, more efficient clinical management, and provides information to improve services. It can be used to discover areas for improvement and analyze areas of excellence. And the NIH Outcomes Management Program is a program that helps with outcomes management. Interprofessional assessment involves more than one discipline, as I said earlier. It includes peer review, audits, and outcomes management, just like in the intraprofessional. It also includes utilization review. Sometimes you'll hear the department, the QI department is the utilization review department. That's an older name for it. It's an analysis of use of resources and identify areas of overuse, misuse, and underuse, and protects the facility from unnecessary and inappropriate use of resources. It's required by Medicaid for specific services and the Joint Commission for facility accreditation. But what we're looking at is areas in which resources are overused, and the example is too many urinary tract infections related to too many urinary catheters. Can identify areas in which resources are lacking, like inadequate staffing, but not listed here. It's also can look at when scope of practice overlaps and who's necessarily the best professional to be performing the skill. They will look at benchmarking, and benchmarking is a method of comparing performance of personal organization to industry standards. Standards of care are based on established models of high quality performance. And for nursing, it's the Florida Board of Nursing, the National League of Nursing, help establish the standards of care. When you look at specialty areas like the operating room, there's a professional organization that establishes a standard of care for operating room nurses. Same thing for critical care and other specialty areas. The Donna Bedian model of quality improvement structure standards relate to material resources, human resources, and the overall organizational structure. And they process standards focus on steps used to lead to a particular outcome. Outcome standards focus on performance of a process. Indicators are statistics that reflect the organization's performance in a specific area. And again, we want to compare the quality of what the facility is doing, compare it to a facility that has a high quality of care. And they must be measurable, objective, and sensitive to changes in performance. Targeting areas for improvement, we look at things. This again goes back to the medical error prevention. Sentinel event is an unexpected occurrence involving death, serious physical or psychological injury, or risk of injury, and require immediate investigation and response. The Joint Commission reviews facilities' response to sentinel events as part of the accreditation process. If a sentinel event occurs, so this is a reportable event to the state, organizations are expected to respond appropriately. They're going to do a root cause analysis. How are we going to reduce the risk of these events occurring again? What's our plan for improvement? And monitor the effectiveness of improvement. Just to backtrack to the sentinel events, so they are reportable, and as individual patients or hospitals, these are public knowledge. So you can look at a hospital and see how many sentinel events have been reported in the last year or two. Breach of care occurs when the nurse does something that should not have been done or does not do something that should have been done. We look at this as neglect or negligence, and so you probably covered a little bit of that when you talked about legal. Increase the number of malpractice suits involving nurses related to deficits in treatment, care management, assessment, monitoring, professional conduct, medication administration, all of those areas. And nurses can reduce the risk of committing breach of care by reporting any problems, especially staffing issues, to the supervisors, remain current in skills and education, and base all care on nursing model and document care response. Other areas for improvement: risk management. Again, the QI and risk management and utilization review, those all work concurrently. Risk management is a proactive component to prevent adverse effects. Reactive components are done to minimize damage from adverse effects. And we should be looking at risk management every day, although there are special people who specialize in risk management. The process identifies risks that may lead to patient, staff injury, or financial loss, and it reviews systems that monitor risks, analyzes frequency, severity, cause of past adverse events, stays up to date on current health care-related laws, identifies needs for patient staff education. So you'll see on many of the floors, they'll have a dashboard. And the dashboard will include things like, when was our last fall? When was our last urinary tract infection? When was our last incident, medication error? These are all areas that facilities target to improve. And so they want to keep the data up front for you so that it'll be on your mind when you're performing care. Nurses are well positioned to analyze patient satisfaction and identify specific patient risks and implement the changes. The root cause analysis is required by the Joint Commission for sentinel events and recommended for adverse events. The goal, again, is really to see where the problem is. What is the problem that occurred? Likely it's a system problem, but we approach everything as though it's a system problem and not an individual problem. And so we want to see where did the failure occur, how did it occur, and what are we going to do about it? What kind of action plan are we going to put into place? We want to reduce medication errors. We talk about adverse drug event. That's experienced by a patient as a result of exposure to a medication. So not necessarily an error, but an adverse event that occurred. So just as an example, if you give somebody an antihypertensive and they drop their blood pressure too low, that would be an adverse drug event. High alert medications, one of the key things is that we want to double check that high alert medications need to be validated between two nurses when you're giving them. And they're medications that can cause problems in older adults, but similar names or appearance with different chemical properties. And there's a few other high alert medications types. Strategies are barcoding patient ID bands and medications. So that's why you see that when we administer medications, we're scanning the patient, we're scanning the medication, and we're doing these double checks. Regulating similar drug names and computerized physician order system, and that's one of the other strategies. This should be part of what you learned in medical error prevention. The one thing that you'll see for the similar names is they call it tall man lettering. So you'll see several of the letters be capitalized and the rest lowercase. Other staffing practices in nursing. Decreased nurse staffing correlates with poor outcomes. The worse the staffing ratio, or the higher the staffing patient load per nurse, the higher the adverse patient outcomes. There are lots of studies that tell you that. Increased nursing workload associated with adverse outcomes. An increased ratio of LPN hours to RN hours is also associated with increase in mortalities and sepsis rates in trauma patients. So we want to make sure we're using our resources properly, because that can improve quality of care and reduce waste. And the reasons are listed here. We want to make it, I talked about this earlier, a blame-free environment. And that is not always the case. I know that I see that, and I know if you make an error, you personally blame yourself, even if it is not anything to do with you, but you still blame yourself. But we want to make sure that we try to keep it a blame-free environment. Healthcare providers can record errors or near misses without fear of punishment, and it helps to identify problems so corrections can be made. And we want to make sure it's a just culture and try to balance blame-free environment with appropriate accountability. Other things that help promote better outcomes are personal responsibility. All nurses, including nursing students and practicing nurses, never perform an act the nurse is unsure how to perform. Show accountability for his or her actions. Admit to errors if they occur. Know the facility's policies and procedures and follow them exactly, and understand how to report errors, what paperwork to complete, how to document them, and to whom they should be reported. Implementation of new protocols, that's the most important step, is educating the nurses and other healthcare provider or healthcare practitioners because about the importance of the new process, the steps involved, and associated reporting procedures. Each individual must take personal responsibility to implement the change. And then we're going to evaluate the efficacy of the new protocols. Part of the quality assurance process is you want to see how well things are working and are standards met or improved. And that's the end. There's one more voiceover PowerPoint on quality improvement.